Don't over-identify with your mental health diagnoses. It's a starting point, it's not your destiny. That's the title of today's talk, and I hope you find it useful. Welcome back to the ACS Mental Health Counseling YouTube channel. My name is Adam Schwartz. I'm a licensed mental health counselor in New York. Welcome back to my series of psychoeducation videos. Today's video is an important one from my perspective, as it involves a basic logical/philosophical error that keeps people stuck in reference to their mental health symptoms. And any issue with such a large downstream consequence deserves more careful thought and better conceptualization, in my humble opinion. A little bit of formal logic for you. Don't get lost in it. I'll move on quickly, I promise. What we're talking about here is something of a category error. A category error is when you assume something from category A is entirely like something from category B, simply because category A has some overlap with category B. In formal logic, we'll call this a fallacy of incomplete comparison or an association fallacy. Here's the fallacy. Mental health diagnoses are entirely like medical diagnoses. This is not correct. These two categories, while similar in some ways, are wildly different in ways that really matter, and they have serious implications for one's prognosis, which is to say one's ability to get better. While there are some neuropsychiatric conditions like schizophrenia, bipolar disorder, that are thought to be neuroanatomically and neurochemically based, most of the disorders that precipitate therapy for most people most of the time are not in this category. A mental health diagnosis is merely a descriptive label that we put on a particular individual's intrapersonal sense and sometimes externally observable behaviors. It represents a starting point. It specifies for insurance whether therapeutic encounter is happening at all. As of the making of this video, these labels are never based on any type of biologically observable markers and are almost never empirically arrived at by the diagnosing clinician, which is to say they aren't directly observed. They are almost always arrived at through the client's self-report in the psychotherapy setting, and perhaps a friend or family member's report if they are brought in as a collateral source of information. Keep in mind, even formal assessment tools like a PHQ-9 or a GAD-7 that the clinician might use are still ultimately self-report, assuming that they're not measuring performance on a task like an IQ test does. So how's this different from a medical diagnosis? The most valid medical diagnoses are observable through a blood test, a gene marker, or a physical deformity like a broken bone or something else. They represent a biological reality that needs to be managed or remediated. Take type 2 diabetes as an example, and I'm going to extend a metaphor here as we go, so bear with me. A measurable blood level, such as glucose or an A1C level, will reach a diagnostic threshold that indicates pathology. Someone might typically reach this diagnostic threshold through a sedentary lifestyle or a long history of metabolic imbalance, in addition to some other genetic predispositions, of course. Now, one would never dream of taking such a diagnosis and using it to justify the continuance of the behavior that led to the diagnosis. Stay with me. To state it another way, if you saw someone you cared about who had recently been diagnosed with type 2 diabetes not attending to their diet in a responsible way, and you expressed concern to them, you could rightly assume that they had lost their minds if they came back with, well, I've got diabetes, I've got to eat like this. But people engage in the same level of preposterous thinking all the time in reference to their mental health issues. They really do. Take someone with social phobia as a for instance. Typically, people develop social phobia diagnosis following a history of social embarrassment and then a sustained habit of social avoidance. And so they then use the label of social phobia as a justification for not engaging socially is completely nonsensical if you think about it. Don't misunderstand me. It is understandable on an emotional level, but it's also precisely the behavior that led you to the diagnosis. If one is to have any hope whatsoever of moving beyond the diagnosis, then it isn't helpful to think of the behavior that led you to the diagnosis as being a necessary downstream consequence of the diagnosis. Because at this point, this just becomes a giant tautology. A tautology is a self-sustaining logical loop that doesn't give you any new information. And it just keeps someone stuck perpetually. It sounds like this. I have social anxiety, therefore I cannot socialize. Why can't I socialize? Because I have social anxiety. That's a tautology. My message to you today is do not fall into this self-sustaining cycle of pathology. And at this point, you might be saying something to yourself along the lines of, But Adam, what about compassion? What about understanding? To this, I would offer the following reply. My orientation to this concern is deeply more compassionate than the alternative. My orientation prioritizes your long-term wellness and recovery over your short-term emotional comfort. Be cognizant, this is important, when you work with a mental health clinician, what they are prioritizing on this front. A clinician should be empathetic, of course, and have a clear understanding of your history, but they should also care more about your recovery than they do about your continuing need for counseling interminably. They should push you into reasonable ways to overcome your presenting issue. And for most people, most of the time, that's all the diagnostic label is, a starting point, a descriptive shorthand. Don't cling to it because, unsurprisingly, if you cling to it, it'll always be with you. Okay, that's all I've got for you today. All the best. Take care of yourself. I hope to see you in the next video.